All right, I would say let's start.
Mhm.
We only have an hour, and if anybody joins, they'll be able to join in. Good evening, good afternoon, wherever you are in the world. Thank you very much, Dale, already for turning on the camera. Claudia, Victoria, if you feel like doing that, it creates a more natural conversation. I think I could say the least. I'm going to introduce myself, then the setting, and then my lovely colleague for the evening. My name is Aaron Scheer. I'm the Vice CEO of NoTube. And tonight we'll have a webinar on the topic of child-led therapy. With me is Marion Russell, and we're gonna be recording this Zoom meeting, which you've already ticked off on the when you applied yourself to it. And afterwards, everybody that is in the Zoom meeting will also get that recording. If you have a question, please raise your hand or also just speak right into it, jump right into it. We're going to start with a little bit of an input on the topic, and then we're going to move into questions. If you feel more comfortable, you can use the chat as well. And our goal is after this little introduction to really have a conversation with you to create a dialogue. And we look forward to spending this next hour with you. Marion, could you please introduce yourself?
Absolutely. So, welcome everyone. My name is Dr. Marion Russell. I'm an occupational therapist by training. I'm originally from Germany, but now I reside in the US. I'm in Omaha, Nebraska. So, therefore, where I am, it is still light out. And I am here today to speak to you kind of from my therapist perspective. So, I've been with NoTube. Oh gosh, I think since 2016, probably around that. Yeah, I think so. That's when it started. And I have worked on the on-campus site at what's called Eating School, but also I'm now, of course, because I'm living in the US, more active in the net coaching, the telemedical side. So today we also want to talk a little bit more, how does the child-led approach work in a telemedical setting, and how does it work in an in-person face-to-face setting? And as my colleague Ivan already suggested, is that this is for you a chance to ask your question, to have the conversation. And so therefore it's kind of a Q&A style. So it's not like a prepared presentation. We have a couple of questions that you submitted that we can absolutely address, but it's more that here, this is your space to say what is on your mind regarding to a child-led therapy approach and what we can do as NoTube. Also for you to see that you're not alone, it's a community. So, and if you are here in a therapist or in a professional capacity, please also take in what our caregivers are saying that are joining us today and their stories, because they are very powerful and very powerful advocates. So thinking about child-led, of course, we say the child is in the middle, right? The most important person in this interaction, especially when we're talking about eating and feeding disorders. And leading, meaning that we, as the person who come around the child, we do have an idea where we want to go, right? So we do have a plan, but yet we're looking at what is the child given us. So we want to foster autonomy. I think that's a word you're going to hear a lot today. And being in charge, giving back control. So that's kind of where I start when I think about child-led. So Alan, what is your take on that? What do you want to add? Did you hear me? We might have lost him. It looks like he's frozen. So I will just wait until he is back. So child-led, we actually, what we talk about is that, oh, there you are. Arman, did you get my question? All right. I was just talking about what is child-led from my perspective, and I was throwing the ball back to you. So what is your idea around child-led therapy?
Yes, in just that moment, my connectivity got lost. For me, the special thing about child-led is that we really mean it. I think it's so easy to think about child-led therapy when you think of the age group of 12, but we also mean it with the age group of, say, 2 years old, and that child can be neurodivergent, that child can have different syndromes that are making it tough for that child to communicate with the world at large. And so with these families, we often see that the caretakers speak for that child, and they think it's completely normal because they know and others don't. And within that translation, a lot of things are lost. And also within that translation, a lot of the issue really is to be seen, the way they translate for that child. And so what we have to do often in eating school for the first, I would say, 3 days is just to give the parents the trust that we understand what this child is trying to tell us. And the way we do that is also somewhat counterintuitive to some, especially when you've ran through a lot of programs. In a lot of programs, there's such a high service character towards the parents. We're going to take your worries, all your troubles. We're going to answer your questions. We try really not to do that and give the families the sense that our patients is their child. And even though at surface level, it seems that often mothers are suffering the most from the situation and they tell us about the suffering, we are not there to treat the mother or and take away that suffering. We are there to learn with the child how to eat. And so how that works is I think about a child that we had last summer. She was blind, deaf, 5 years old, very autistic. And what she did to communicate with the world is do humming sounds and stomp her feet on the ground. And the communication that is possible there is to lie down next to her and stomp your feet on the ground for half an hour and start engaging in some conversation that at the end of the day builds trust, because a lot of the kids that have had experiences with medical professions in their very, very young and challenging life, those experiences weren't very good for them. They weren't asked what they want. They were prescribed things. They were made to do things. And also around their mouth, there was a lot of things happening without their knowledge and consent. And so we first have to heal a little bit those past wounds from experiences, which is why our eating school is not looking like a hospital, which is why our doctors aren't wearing white coats. So it's really to give that child the idea that he can trust us, the whole team, in order to make some experiments and also to understand that if they have a good day and then a bad day, nobody will be angry with them. That we understand that it's a path. And I think my last point, Marion, is it's always about the next step in the child's eating journey. It's not the parents come to us with so much sort of frustration heaved together and they just want to fix it. And we really understand it. And we would love every child that comes to us to be a perfect eater at the end. But what we focus on is the next step. And if that means you only ate toast, then it means now you eat brioche, for example. Another form of white bread is a step. And I think there a lot of parents come with us and are like, how can you be happy with this? Because they've already lost a little sight of what this is about and they're fixated on the end stage of this whole process. And we have to just sensitize them that we are in a journey, and this child, if it's 2 years old, will have this journey for a lot of years, and the years past that as well. So I think that would be my first thoughts on the topic. Marion, do you still have some additions?
Yeah, and I think too, I like the kind of the idea around the caregivers, right? So, what we capitalize on is like what the child comes with is curiosity, no matter what age, right? So, what is happening? So, we're tapping into that, bringing that curiosity into the world of food, and we often have to tell caregivers, enter that world of curiosity with your child. When was the last time you ate on the floor? When was the last time you ate it with your fingers? When was the last time you ate a pureed meal? People say, well, not very often. I don't remember. I think I ever did that. So kind of bringing that back to the level of the kid and exploring it with them, building a different relationship that's not kind of laden with frustration, with expectations, with pressure. And caregivers do come with lots of pressures, right? I mean, they do. They have their history, and we acknowledge that. It's with them in the room. When I would ask you now, what is your association of mealtime? Depending on where you are in relation to somebody who has an eating or feeding difficulty, you might bring on very different word associations, but that's with you at the table. So And Aaron was talking about eating school, and that is the on-site program that we offer at NoTube, where you're going to be for 2 weeks in Graz, Austria, and you are immersed. You're immersed in the world of food that looks very different from what you experience at home. And because a lot of times there is trauma expectation around the table. So you put a kid in a chair at a table and they know, oh my gosh, I have to eat. So we remove that. We start on the floor and where the idea is around exploring curiosity. Parents, caregivers have to eat themselves. Often they forget what it's like to enjoy a meal. So we tap into that too. So we don't leave you behind, we'll take you with you on the journey, but the person who is leading it is the child. And we as the support team, we come alongside. So make sure that you are not falling all the way over here or all the way over there. We are kind of guiding you. And it always reminds me I used to live in Maine with the ocean and the boats that have they guide you into the harbor, make sure, you don't crash into the reefs and ever. So that we help you to get there. We give you that support. And I think when we say child-led, caregivers sometimes get nervous. They get scared. I'm like, what does that mean? Like, are you not doing something to my kid? Are you not, are you what I don't want to just play with food. I'm like, well, it's not just that, right? So the idea around doing something to your child, that's not child-led. That's not child autonomy. So we move away from that. We've tried it. We've all tried it. So let's try something different. And that takes some time to get used to, kind of taking that step back. Sometimes we say like, oh, bring a magazine, do something totally different. Don't watch your child eat or engage with food. Don't praise because it should be fun. They should enjoy it. So that's a little extra tip to that. We invite the caregivers on this journey of curiosity.
I would say it even a little harsher. We tell them to let go.
Well,
Because
yes, yes.
it is, interestingly enough, especially on the picky eaters and on the ARFID front, but especially on the picky eaters, we see a lot of times that it's the last child or the youngest child in that family. And also for these mothers in families where mothers are the primary caregivers, there is a sense of identity with this child. There's a sense also of me as a mother is the person who makes it possible that this child will be able to eat and can face all the challenges. And when we say we got it, they feel attacked because nobody has ever said it and then done it as well. So we do push back where there is this sense of protection and motherly protection, which is a loving, beautiful thing. We have to push that back a little bit because often it is part of the interaction issue at hand. And that can be tough. That can be tough. And we go through that, and we're not going to leave them alone and we're not going to kick them out, but we're going to tell them that you need to let go and all the pain that comes with that. We have professionals, we have setting where exactly those kind of challenges for the parents are being addressed, but not when it comes to the child wanting to learn to eat.
Mhm.
With that, I want to open the floor, and I'm curious if you brought some questions for us.
Well,
Hello, can you hear
Hello.
yeah,
me?
Yes, we
yeah,
can.
Oh, sorry, did I interrupt someone or can I?
No, Jessica, you can ask your question. Dale, you might have a question afterwards, I saw.
that's fine.
Perfect. Thank you. Jessica, please.
I have a son who is 6, almost 7 years old. He has ARFID. When would you typically see that this diagnosis is finished? Will you see it in teenage years? Is it adulthood? I know it's a long-term thing, but in your experience, when do you see this kind
Let
of?
me just ask one question back, Jessica. When you say
Mhm.
finished, what are
That
you thinking about?
that he has a good relationship with food, that he's not afraid of anything really. I'm not talking about, eating really extreme things, but, having a normal meal with anyone and it's not a problem.
Thank you.
Mm. I think it's a process and it depends where you're starting from, right? And so so there's no like timeline to say like, well, in 2 years this will be done or they're going to grow out of it, right? So we hear that a lot too. There's some picky eating which is typical development, but if your kid, you've already said, has a diagnosis of ARFID, so you're going to look at the components, so the fear component, the sensory component, and how is that addressed? How is that being supported to kind of move him forward to be more open to food? Is that, will he have a relationship to food that has no problems at all? We don't know, right? So we're looking at what is the best way for him to function and to engage in a mealtime that's meaningful to them and that is nutritious, right? So that's kind of, you have to think about the goal setting. So that's kind of where I would start, with. From my experience, I have seen children and young adults with ARFID who have expanded their food repertoire, who can now reflect on, oh, yes, this food, oh, that's still not, I don't feel good about it, but they know why they don't feel good about it. And they have strategies to go about it if that food is offered at a mealtime. So that's the big piece of it too. What strategies can we give you on the way?
I would just add, waiting, I don't think is a good approach because often with ARFID also it's a what are you trying to say through this problematic behavior. So I think when kids come into their adolescence, they're more open to therapeutic support, and then they can talk about it, they can explore ARFID, what it means to them. And then the other thing which I find so interesting is that when we have an adult with a very restrictive food behavior, it's not a problem anymore just because they're an adult and then it seems like they chose to. But when you can probably all think of a person in your private social circle that eats 5 to 10 things, but they're sort of, oh, that's what they like. And so I think we have to also sensitize that with kids and especially children development, there are some expectations and at this age that should happen and that is normal. And so we sometimes, I feel, are a little more critical when it comes towards kids and their development. Once they're an adult, that's just who they are. And so, Jessica, I think there's no real answer as to when it will be done. And I'm sure there are also grown-ups with the same challenge. And yeah, everything more, we would have to know a little more about the context, what you've tried, but maybe we move on to the next question, if that's fine with you. Thank you very much.
Yeah, thanks.
Dale, please.
Okay, I'm calling on behalf of my grandson. My daughter had a very difficult birth, and as a consequence, my grandson suffered a stroke during the birthing. He is not yet 3. His eating, and he may be on the spectrum, although he is making progress. If he is, he's highly functioning. His language has been delayed, although he does speak in very simple. He doesn't speak in sentences, but he does say words. This eating problem started to happen, I would say, in his first year as he was being weaned off the bottle. And it became apparent that he was very fussy about what he was eating. And eventually, I mean, this created all sorts of stress around eating time because they were, of course, putting on a chart how many calories because they were trying to keep him within the growth curve.
Yep.
But eventually, his eating habits were confined to just eating these flavored yogurts and in a package, and that's all. So they thought, there might be something wrong with his esophagus. They did all that, and he goes to a doctor. He goes crazy because, like you were saying, he associates anyone in a white coat with a lot of
Yes.
problems.
A
And
lot.
yeah, so
caregivers actually too.
yeah, they couldn't find anything wrong with, mechanically, There was some regurgitation, but it got to the point where the therapists were recommending that he go on a tube, and
Yeah.
eventually, about 9 months ago, I think he was put on a tube, and as a consequence of that, he has completely stopped eating. Um, he was eating a little bit, and then we were introducing sort of like you were suggesting, sort of playful and circumstances where eat the food was there, but he didn't have to eat it. It was just placed on a table where he could graze as he so wished. And I thought that was somewhat effective. But anyway, now he's on his tube. He doesn't eat at all. His growth, he's back on the growth curve. He's growing, he's filling out. He's in his he's engaging more with people, making eye contact, and we're hoping that he'll make a full recovery. But I'm just wondering what the timeline is, because it's been almost a year. If anything, because he's so reliant upon the tube for calories, my sense is that his parents, who are, it must be very hard on them to be dealing with this. And they're very patient, but I think overlaying that is a certain amount of stress. And I think they may telegraph that to him. It'd be hard not to. But I'm thinking, well, like, what are the next steps? How do we, he's gaining weight, but how do we get him back into a, to expose him to food and to encourage him to eat? That's kind of, I think,
That's
where we're at.
Yeah, that's a great. First of all, Dale, wonderful advocating for your grandson. Thank you for
Mhm.
being. That's pretty amazing. So, yes, thumbs up for that.
By the way, they don't know I'm doing this either, because I don't
We
want to be
won't
seen
tell
as
them if they
interfering.
contact us.
But
But thank you for reaching out for help because, yes, so first thing what I'm hearing is he has the ability to eat. Okay, so that's the first thing I'm hearing. And then
mhm,
the tube was placed originally for, let's say, nourishment, for growth, and so on. So what
mhm,
you describe and what you said, the fear and the stress, what we call tube dependency, right? So the kid gets
mhm.
stuck in it. So the question is here, is it medically necessary to keep the tube in? Are there medical conditions that keeps him from actually eating orally? What I'm hearing is that he is allowed to eat orally. He just stopped because he had the tube. So when you have a tube, you're constantly about full till here. So if I will offer you after a three-course Thanksgiving meal, I'll offer you another dessert, you're probably not going to want to eat it. So
Yes.
there is no motivation to eat because
No.
it's absolutely full. So my first thought was, why don't we tube wean? Why do we wait?
Mhm,
Right? So because he is able, I mean, we can work with whatever the kid has given us. He's able to swallow, he's able to eat some yogurt. We can build on that. So my question was, why are we waiting? So the next step
mhm,
was to figure out, is this medically necessary? Is there a medical reason that he needs to have the tube? And what I'm hearing is it's not, because he is able to swallow, everything is okay. We have weaned
mhm.
children with complex medical conditions. NoTube is a place where people come, they've tried other stuff. So we are not afraid of that. And we have a good success because we have a different approach. So I would recommend that your daughter reaches out to us and, just you can do a free evaluation. She can just call, she can chat with our colleague Ava or Caroline, depending on who is available. And we can give you some specifics on what next steps would be. But you can't expect to have the child starting to eat while feeding them up with the feeding tube. That is
Yeah,
contra.
that's almost common sense.
It
That's a
is,
catch 22. I don't know.
but yet
On the
there's
other
no
hand,
they are there and the exit strategy is missing. So, and that it was great to have tube at the beginning because it really helped. He has grown and everything. We've met those things. So
mhm.
now let's see how we can get rid of it because I don't see that it needs to be there, right? Aaron, I can see you want to say something.
Well,
So
Well, I just want to add some hypothesis as to why is the tube not being. That was also part of your question, Dale. Like, what's the next step? It doesn't seem like there is one. And what I
Right.
see often, what is being not highlighted enough, there's great comfort with a tube.
Hmm.
Like feeding is one of the central jobs of the care system to provide the child. You are simply taken off that job. And not only the parents who would come do that responsibility, of course, but also the entire medical community. So often, what we find is that doctors give the tube because they don't know a better way to help. And it is a way that does help. But then they are not aware, and it is actually, it's an intense process to wean the tube. The way we do it is we have a very, very daily look at the weight of the child. Then we take the tube out if we feel like that child can lose a little weight. And then we see what they can feed themselves, what they can eat. And then but we look at that every day. It's not like take the tube out, hopefully he eats. If not, let's just stick it back in, because that wouldn't be responsible either. And the last point that I see with parents, especially with neurodivergent children, children are challenged in other ways, is that eating time is a huge fuss. I think again the child that I told you before, who's blind and deaf, eating 200 milligrams of puree with that child takes about 1.5 hours. That's a long time for 200 milligram. In the tube, Marion, correct me, that would take about what, 20 minutes, but nobody has to do anything.
Well, it depends on the mechanism. Yeah. So if you have a pump that does it themselves and the flow rate, and yeah, there are different ways of doing it. You can do it with a syringe,
Yeah.
it's really, really fast. And it is safety. It creates safety. So we are not saying like we don't
Yeah.
want to say like tubes are bad. It's the when you need to think about what was the original goal? Why was the
Yeah.
tube placed? And you have to revisit, is this goal met? Or are we still working on this goal?
Mm.
And if 3 years later still working on the same goal, you have to reevaluate. Like, is this actually still the proper way to go?
And a metaphor, I think, that maybe also helps us think about this in other terms is if you are depressed, then antidepressants are a perfect step to alleviate yourself of that challenge. However, 3 years later, your life looks much better. And now we say, well, maybe it's time to get rid of those antidepressants. It's very understandable that the person would say, but if we take them out, what could happen?
Hmm.
And that is something where we have to be very caring for the parents, because they have to trust that once the child will start eating again, in the case of your grandson, it's not going to be a redo of the whole challenging story, finishing with a tube. And so there is this whole thing of like, once we got there, what are now going to be the challenges? And those have to be embraced. I'm sure no one wants this child to just be on feeding tube for the rest of their life, which is medically quite possible and super easily done. Like,
Hmm.
and so really it's this seeking a little discomfort again. Is the whole care system ready to take that step? And you've also said that he's doing various therapies and he's developing in his speech, and that's wonderful to hear. So also, are there resources available right now to focus on this issue? Often we have kids that just came out of a huge operation. They have 10 different therapists. So can we focus on the food issue now? And if so, are we ready to climb that mountain really? Because just leaving the tube in is like staying at the bottom of the mountain and asking yourself,
Well, just as a follow-up, like what are the
please.
techniques for weaning them off the tube? You're saying to remove the tube, but that would, I mean, you're not, they would
Yeah.
remain, the implant would remain, the port, and then, so what would how would you go about weaning someone off, being a tube dependent?
Yes. So it's a very individual process. So we don't have a formula to say like, okay, 200 mLs less and stop this and then add that. So again, it's a child-led and very individual approach. So we would look at what is the kid giving us, reducing the tube, watching are we getting some more. It's kind of a dance. If you move too fast in one direction, the other person will have to go like this. We don't want that. So because if you get a kid too hungry because you pull the tube and then see what happens, that's not going to make him eat. Okay. So we to really, it's a process. We're not rapid. So it's a really child-led. The kid needs to be on board. You cannot overwhelm them and take this away all of a sudden. So it's a supported, a guided approach. And so I cannot give you a formula, right? So, and but we will look at what do they take. We weigh daily, we reduce, we watch, okay, what's happening orally. We do allow a 10% weight loss, because that is a typical loss when a child transitions, let's say, from a bottle to solids. And if a kid comes with very, very low weight, we might even not take that. So we will really look at the kid and try to work with everybody there, with the care team, with the caregivers, your daughter, and see where we can go get there together, because we want at the end that this tube stays out. So that is our goal, right? Not just like, oh yeah, oh, you're done. Here you go. You have a week, fine, goodbye. So it's like it should stay out. So we stay with you for 35 days after the last tube feeding to make sure that you can maintain it, to make sure that, because then there comes the first cold, there comes the first thing, and then everybody panics and the tube is going to go back in. I'm like, not necessarily, right? So it's this very individual, very child-led approach. And again, you can do it from the comfort of your home. We have a program that's called Net Coaching, because a lot of families can travel to Graz. I understand that. So we offer that piece too.
Yeah. And before we come to the next question, last
Yeah.
point from me is empathize with not understanding what hunger is. If you've been on a tube fed for a year, you
Yeah.
forgot that sensation. It's like being in a warm climate for a year. First time getting cold is really irritating. And so, sticking with that metaphor, we don't try to just stick them in a fridge. We got to
No.
find that hunger. And if that hunger is scary because you haven't eaten for 3 days, that's a real scary hunger. And then you're going to block down. And so the part is also timing. A lot of parents, they have a fixed feeding schedule on the tube, and they're like, why doesn't he eat breakfast? And the answer is often, well, the last time you tube fed him was an hour before. And so there we see how many calories do need to be given to the tube in this weaning process. And then when can we give those calories? And there we love the early night, because then you have a chance to be hungry for breakfast and lunch. And if then breakfast and lunch isn't successful that day, then you can add a little bit in the evening. But really, it's this sort of daily looking at it, which gets that process done.
Yes. And we want to get tubes restrict in some ways, right? So we want to make sure the kid can move around during the day and kind of bring some more of the family routines into their daily life. So we will look at reducing the tube feedings early throughout the day, so that we can leave some room for food exploration. Again, if you're fat till here, you're not going to eat. I don't know. We don't. So, we don't do that. So, bringing in that and kind of what is the routine already from the family? Often it is absolutely circling around when is the next tube feeding. And so that is where the whole day is structured. And it's like, so what do you do outside? And
What else does life offer? And so
right. So
it's finding
you bring
joy.
that in, we bring that into again. And that's why we said child-led too is like, go outside, try it somewhere else. Don't be like a checklist person, but it's a really hard transition, because that kept your child safe and fed. And now somebody comes and says, we're going to take that away. But we're going to do it slowly, and we're going to do it together. And you have access to a team every day. So, we'll kind of take here we go. We're going to walk. And it's not a highway. We're going to take a detour once in a while, because that's what the child has given us.
Yeah,
But
and
that's
also, yeah, and it's walking 2 miles.
yeah, I mean,
It's slower than you want. It's a
yeah,
3-year-old. How quickly do you think that walk is going to be?
yeah, totally.
Thank you very much, Dale. Alina, you had a question for us.
Hello, good evening to everybody on the call. Yes, I would like to speak to you. You probably know my case. I have already been in contact with the team in Austria. I am the mother of a baby girl. She's 2 years old, and she's been diagnosed with hyperinsulinism since birth. It's a disease which comes after the pancreas release too much insulin into the body and kills the blood sugar in the body. So it's been a hard period of time for me. We've been on a long journey. We've been on a tube feeding for a year and a half. Last year, I've been in contact with your team, and I've been so grateful to see that she could come off the tube after so long time. So I've been so happy to see my child having normal meals. It's been difficult because her diagnosed, we couldn't let her be hungry to come off the tube, as you said earlier, because she has specific times when she had to eat and maintain the blood sugar in the body. So we are off the tube. She is still eating well. She is gaining normally. She is a perfect normal child. However, whatever it comes from the spoon is not chewing. She doesn't have the process of chewing stuff. She's still on the purees, and she only eats when she wants from her own hand. I would like to know what is actually the next action I can take to help her in improving her feeding. She's eating perfectly fine. She's drinking well. She doesn't have any problems with that. But the fact that she doesn't eat, like, she doesn't have the mastication process when it comes from the spoon. She eats sticks by herself. She is chewing what she wants, like carrots, cucumbers, whatever she wants. But she doesn't want to eat properly and chew whatever comes from the spoon. I have tried to make the soups and purees a bit bigger with bits in it, but she just makes herself sick because she's not stopping the food in the mouth to eat it properly and then swallow it. So that is our problem at the moment, and I will still need your help to fix that.
Okay, so I am going to ask you a question back. Whose problem is it? Does she have a problem with it, or do you have a problem with it?
What do you mean? Is it the problem?
Is she bothered by it that she can't eat by a spoon, or are you bothered by it that she can't eat by a spoon?
She doesn't eat by herself. I have to feed her.
So
even it comes from my
cucumbers?
No, for cucumbers and snacks, that kind of food, I always give it to her, and she just walks around and she just eats whenever she feels hungry. She eats sticks, she eats chips, she eats eggs, even eggs. She likes to eat them. But when it comes from me and from my spoon on a normal lunchtime meal or dinner, no, she would never accept them.
Okay, so and I can tell you right now, she wants to be in charge. So she doesn't want it to come from you. So what I would, but I don't know her. I don't know your case either. So my first thought would be like, can you teach her to spoon feed herself? That she is in charge of it, that she can spoon, or does she have to? Like, is there a way that we can use her skill set that she can eat whatever you are offering, but on her own? I think that feeding piece, she's past it because she's eating herself already. So why are you now coming with the spoon? That's confusing. So, for her, I don't understand. I am eating. So why are you now want me to eat from you? Does it make sense?
Makes sense. If I'm just giving her, I've tried that as well. If I give her the spoon, she would just play with the food. and nothing will go into her tummy. And this is what is making me worried, because she should actually eat a good amount of food for her blood sugar to stay up and above the limit, which is been set it by the medical team in London. So I think it is just actually me panicking to see that she's playing with the food, but she's not eating properly when it's the time for you to eat. You know, it's like, what's going on?
So, and I think there's your pressure, absolutely understand. But so you, I think there's a step in the middle that we're missing. I think what I'm hearing is like going from all the way now accepting a spoon. There's so many steps in the middle of it that we need to address. From what is fed, where, when, how. Are there other ways? Like, can she drink it in a shake if it's time to eat now? And feeding is just a new skill that we are trying to want her to do. Don't teach that during a time where she has to eat. If it's a time it's really you're on because that is your medical condition, you give her what works. So if it's a shake, if it's a smoothie, if it's a something that she can take, so she has that settled, and then we can work on the feeding on the side. Maybe she is not a puree eater. You know,
maybe she's not. Yeah, I wouldn't know that until
Yes, maybe she needs a sandwich. Maybe she needs a fork. That is easier to poke, you know, than the spoon is actually not that. It's not that easy. You have to really use your wrist. It's difficult actually. Fork is a lot easier.
And I would add, Marion, also, Alina, I don't know your child nor your case, but I would think that your child has had many difficult experiences with spoons.
She does, to be honest. Or
from also previous.
A
lot of time when disappointment is in the room, a spoon is very close, it seems. And I think you telling us that you've worked with us already, that you're not surprised by our answers, because we usually, that's what I said before.
Yeah.
She seems, I think it's wonderful to hear that she's developing. I think it's wonderful to hear that she's eating. And it's even more wonderful to hear how strong-willed she is. She's not taken, and this is how I would empathize with her. She's not taken that defeat. Because being spoon-fed by you could, and this is completely just my fantasy here that I have after hearing this for a minute, but she's not going to take that defeat that she has to, because that's what the experience is, eat off your spoon. There are multiple different ways. I look around, I have a bowl here. I can put the bowl straight to my mouth. I can put the food on the table and just shove it into my mouth. I can make it into a ball. I can put bread around it. So really, I could maintain my diet very easily with completely eliminating cutlery from it. And so I think that's also what Marion is trying to say by whose problem is it? It's not your child's idea that we as a society have decided cutlery is the way to go about it. And so underlining everything that Marion has said, if there is a need, that's your need. But if there is a goal in her development, she's gonna tell you, and when she's ready for that, she will do that. But it probably will be way after whenever you are ready for that.
Yeah, well, you know, she's been transiting to this period when she had teeth pain, and I was so scared that she will stop feeding completely, and we would just need to go back on the NG tube. But thanks God that didn't happen, and she's been a good girl. So that's the reason why I want to do more for her, because I know she can. And I just want to help her a bit more, but I just need the right advice. That's why I joined the call today. I think I still have things to learn from you. You're doing an amazing job. I'm just saying that because I've been in the contact with the team, and I know how brilliant they were. I've been a very difficult case because, as I said to you, she had we couldn't let her be hungry. As you've mentioned earlier,
that
and that
does
was
complicate
even harder for the team to deal with.
Of course.
But thanks God we've managed to take her off the tube, and she's
Yeah.
doing well. It's just one more step until she feeds normally, but I'll just give her time then.
It's many more steps, Alina, and the goal is not normal. The
Yeah.
goal is fine. And I think before we move to the next question, I want to just give you a little tip that you can decide or not if you want to try. And maybe Marion, you have a very concrete tip as well. And of course, this is not like customized to your child because we haven't met her today. But I would give a little experiment for the whole family. Throw out the spoons for a week. Spoons
Okay.
are just take all the spoons in the house, give them away. Then everybody else also knows how it is to not use a spoon. And she doesn't have to be scared, and you'll be fine.
Okay.
Just spoon-free week. Because this is what your beautiful daughter is suggesting to the family. What a wonderful idea. And all of a sudden, you guys have problems with your soups, and she's actually going to be quite fine. Marion, what can you add maybe?
Yes, I love, and sometimes it helps to kind of turn a thing on its head, right? Because we have such an idea of what is normal, what does mealtime look like. So what we used to do in Graz at the eating school too is we like twitch it around. So she becomes the feeder. So she will spoon feed you or somebody else in the house that kind of, and for you to experience what it's like to be fed. And I think that is it takes an interesting perspective. And again, I would really, if spoon feeding is the thing you want to do and you want her to have her help prepare meals, stir stuff, start with not eating, like using the spoon for something totally different. Serving, spicing,
Doing
stirring,
flowers.
doing
You can
whatever.
fix flowers. Yeah.
Yeah, do whatever, but not eating. And then, and also, is she going to, I forgot how old she is. Is she going to a
She's
childcare?
2.
She's,
Wonderful.
oh my
She's just
God.
2.
I would have been
Alina,
nervous.
she has time. She has more
Don't
time than
even
any of
worry about
us.
Okay.
Don't even, it's
Yes,
really just
yes,
wonderful how far
yes,
she's come in such a
absolutely.
short
Yeah,
time. Maybe do nothing that we tell you also because your daughter is working extra
yes,
time.
Okay.
absolutely.
Brilliant. Thank you so much,
Thank you so
guys.
much for the
All right,
question.
you're
Thank
in a
you.
good place. Nothing to worry. Claudia, I have a question. You're on
Yes.
mute.
Yeah, sorry. Hi.
No, no,
My
sorry.
son is 4. His name is Finn. We live in Ireland, and there's not a lot of support. He was born very, very small. He was 430 grams. He had the feeding tube until he was 2 years.
Mhm.
And at that point, he kind of decided he wanted to eat.
Yeah.
And it's all about what Finn wants. What Finn
Uh-huh.
doesn't want doesn't go.
Yep.
We've learned that. I figured out at some point that he wanted to feed me, so I let him feed me.
Mhm.
And we sat on the floor, and we're actually coming to you in the summer, so we're gonna be,
Good.
yeah.
Okay.
So our issue is mainly that doctors in Ireland are very focused on his weight.
Yes.
His weight is fine at the moment, but only because, like, at some point I just said, look, he's not getting a peg inserted. He can eat. He can swallow. We never had a swallow study, but he never aspirated or anything. And then they didn't want to do a swallow study. Different story. But he is eating. His problem is textures.
Yep.
And he wants to bite into a crisp, but then he gets the big fright and he doesn't know what to do from there. And he's also very, very active. So he gets up, he runs around. There's something that I want to play with. There's something I want to have a look at. Oh, look at that flower. He just doesn't sit down, ever. And that wouldn't be a problem for me, as long as he took whatever he wanted to eat with him. And he doesn't seem to have that hunger feeling because he was on the tube for so long.
So is he off the tube right now? Is he off the
He's
tube?
off the tube. He's off the tube, but he's just maintaining his weight by drinking high caloric drinks.
Okay. Got it.
Which is, when he's sick, it's an absolute no-go as well. So he just loses loads of weight. So my question is just how, like, you just touched on the subject, but how do you get him to experience that hunger feeling? Like, do you just let them not eat nothing for days and then hope that at some point, it clicks, because I don't think it's going to go that way.
No, I think you already answered your own question.
Yeah.
The idea around, like, just imagine, everybody knows the word hangry, right? People are like throw this around all the time. And when you actually get so hungry that you can't function, you are not going to eat. There's not the connection. Okay, if I now eat, now I feel better. You're above that. It swung the other way. So I think we need to look at, okay, how many of those drinks does he take? Is he constantly full? Like, have we now just replaced the tube feeding with oral drinking of those shakes? And look at the timing. And then often too, if it's textures, then we got to put some other supports in place for him to kind of tolerate the textures. Very often kids say like, well, I don't know what happens when I put this crisp in my mouth. It's like all over the place. Like, I don't know what that looks like. So we take it like I would mesh the crisp up in the back and see, this is what your teeth are doing. It looks like this. But maybe he's not chewing that much. So there's still big pieces and all over. He doesn't know what to do with it. So we need to go a little bit back, like when you teach somebody who is 1 year old, right? Or 1.5, or, so when they start eating solids. So you have to go back and kind of take it there. And you might jump the puree stage, because purees, let's face it, it's not everybody's cup of tea. So, whatever is mixed in that thing, so it's okay. So we got to figure out what sensory system can we build on, where is his comfort level, and where do we get his buy-in? Where do we get his curiosity? Because we might have an idea of what we want to offer, but that's not what he wants. It's not lined up with his sensory experience of the food inside his body. So, we need to look at that. And then he sounds like a curious kid. So let's use that curiosity and really tailor it to look at food rather than something else around. So I think there's a lot that can be done.
Okay.
I,
Okay. So
I
you think
think,
you can get him, not
well,
as distracted?
well, Claudia, we're a very confident
Yeah.
organization, and
Yeah.
the numbers of children that we're able to help really allow us that. My alarm bells rang a little bit when you say what Finn wants, he gets. If that is your reality, learning is not really a possibility, because learning happens outside of or on the edge of the comfort zone. And so what we often help families with is, how can we get in that learning zone, which isn't yet the panic zone? Because the panic zone is a mother who says, are you going to starve my child to death? But it's very close, that zone, as you can maybe imagine. And so I think with this general mindset of, if he's dictating what's going on, their development is difficult. Because if I could say that I'm the only one in charge and I tell you what I eat for the rest of my life, it would be chicken wings and nothing else. I'm a grown up. I understand I need to eat more things. But if I'm in a world where only what I want goes, why would I ever eat something that isn't fried food? I love fried food. And so this is something where we also need to help you and your whole family, that yes, what Finn gets, he wants, because he doesn't want a lot, but also where there is that curiosity for new things. And there I would also think puddings are a really fun thing to do. You can also add so many calories yourself to pudding in a way that doesn't make them go bad. Butter is my favorite. So puddings are something. And then also maybe wherever he's running around, and maybe whenever he is taking a little break, just needing a little break, have food be there. Like, for example, that pudding that you tried last night and it was difficult, let that stand there open. So I also like to sometimes put just food around and see if children register that thing as food. Maybe they chug it, then I'm happy. They've judged it as food. If they completely ignore it, I need to figure out something else. But if I let a child that's going to be hungry very soon sit next to a tub of chocolate pudding, beautiful things can happen. And so really just like that mixture of like supporting and waiting. And there I'm stuck on your picture of the dance, Marion. It's going to be a dance. But I think you should maybe look at that part of the story that is what he wants, he gets, because he wants high caloric drinks right now, and he gets those.
Yeah.
Yeah. And so there it's just a little bit about opening the horizon, and we're very much looking forward to meeting you in the summer, Claudia.
Likewise.
And
Thank you.
your beautiful child. Thank you very much. We would have time for one last quick question. Otherwise, we would just fill it out. Astrid, maybe you have a question too. You've been such a patient listener.
Thank you very much. I'm a pediatrician. You already know me. I just wanted to ask what things you add to the food to make it more hypercaloric, because we have a lot of children who have problems with thriving. And we add, for example, butter, sweet cream, then we add maltodextrin, oil, and things like that. What else do you add if you don't give the hypercaloric drinks?
So we also love avocado. It's just it doesn't change the taste, and it's nice and creamy. So that's usually a really nice one to do. Mascarpone is a good one if you have like a fruit based that kind of goes together too very nicely. Yeah, butter, oil, people put that in. Cream, you've already mentioned that. You can add some calories, like if you said like Ducal or like the maltodextrin that you've talked about. And I would really, but even I always say like if you are enriching the food, I think you know that. I'm just telling it to somebody else who doesn't know that. Often the volumes will go down what the kids eat because it's so full, right? So there's much more nutrient density in it. So that's kind of people gonna get nervous. Oh, my kid eats less all of a sudden. Yes, but you've increased the density of the food with nutrients. So yes, of course you will eat less, but that's kind of would go.
I'm going to answer it from a cook's perspective, because I also was privileged enough to cook for a lot of eating schools. When people add butter to things, they sometimes forget the mouthfeel and how that changes. Oily lips, just as a starter. So I think there are two things that if you have a copious and too much amount of fat in a dish and you have that layer on top, there are two things which are really helpful, and one is egg yellow. So like basically the general idea of making mayonnaise, then you don't have a tub of oil. So adding some type of yellow egg protein, and the other one is a little bit of flour, also manages to sort of capture that fat in, and now it's again an appetizing thing. And last advice, anything that you're enriching, you still have to be able to eat it yourself.
Yes.
Like I don't allow any type of gross things, and like why would they eat it? And Marion, you mentioned it before, but years ago at NoTube, once we did a fun dinner.
Yes, I was thinking that.
Where I pureed everything.
Everything.
Everything was a puree. And then the parents were like, well, that's not very tasty. And our answer was, yeah, we can see that. And when we tried those purees that you brought for your child, how can you think that's appetizing? So really, it's not only calories, it's not only that. For food to be fun, it needs to be yummy. And that is just true for children and grown-ups alike. And with yummy food, maybe we'll leave it at that.
Yes.
Perfect. Thank you very much all for coming tonight. Dale, I also want to help you that in case you have further questions of also how you could broach that subject to your daughter and to your wider family, don't hesitate to contact us further. We would also in another, that's that free evaluation where you have the chance to talk to some therapists of us for free for half an hour and talk about next steps. I just
thank
wanted
you. And you're going to send a video or
we're going to recording after. Yes.
The recording of this session, which is also something that you could look at with your daughter, just saying, hey, I'm out here trying to support. Thank you all very much for coming. Marcus and Jeneline, welcome, but also goodbye, because we're at the end of our 1 hour. Maybe there's been a slight issue with time zones. I'm sorry if that was a confusion. Thank you for participating. You'll get an email from us, and you can also find the link to the free evaluation in the chat right now if you want to look into that. Please, Marion.
I also wanted to, real quick, we do have a YouTube channel where we have all our other webinars kind of housed. And so if you want to know more, learn more, feel free to go check that out. And we are here, so help@notube.com. You can reach us. So we are here. So thank you for coming and for being interested in the topic and being open to child-led therapy. So
Have a wonderful evening. Goodbye, everybody. Thank you.
Thank you.
bye.